We're going to move on to our last presentation by Deepak Asudani on keeping the spotlight on equity in healthcare access and delivery. Why are we where we are, and where are we going to go from here?
Thanks, Wes. Hi, guys. We all ultimately want to do is provide good care. And thanks, Andrew, for setting the stage for disparities while he talked focused for cancer, but there is a plethora of avenues where the disparities do exist. We are charged to talk about why are we where we are right now in terms of disparities and where do we go from here. That's the challenge that lies ahead of us. Historically, in 1990s, there was a series of articles where it was clear that the disparities do exist, and Congress actually charged the Institute of Medicine to look into it more closely, and the findings were pretty clear that there was a lot of disparities. For instance, minorities were less likely to get bypass surgery, and they were more likely to get aggressive surgeries, including lower limb amputations for diabetes. And there's a lot of findings that startled the whole scenario, and subsequently it was taken as a priority to make sure that the disparities get taken care of. And going forward, every year the AHRQ, it demands an annual report, like where do we stand as far as the disparities are concerned. So overall, the access has gotten worse, and disparities haven't really changed. So we are still, like a decade later, we are still where we were. And when you think of disparities, it's not African American, it's not Hispanic, Latino. It has a lot of flavor to it, a lot of shades to it. It's the socioeconomically disadvantaged population, the ethnic and racial minorities, whether Native Hawaiians, Alaskans, women, children, the LGBT community, people with disabilities, homeless individuals, migrants, and incarcerated individuals. And there are many shades of disparities, and I'll probably not spend a whole lot of time talking about what the disparities are, but I can go on and on and on and emphasize beyond doubt that there is a lot of disparities that exist. In fact, the New England Journal, it came up with a follow-up article to the report saying that there's an enormous amount of data to support to demonstrate that there is a lot of disparity. So these are some examples, and it's very clear that the disparities do exist. If you look at the child on the right side, he has 5 fewer years to live just because of his ethnicity, but just because of his race. And a lot of comorbidities have poorer outcome in African American population. And this was a study done by Harvard, and what it shows in the nutshell is, in the far right are the hospitals which were identified as low quality care, and based on the reports of the hospitals. And on another leaf, what they found was these were also the hospitals where most African Americans got their care from. I'll be hard stretched to think it's a coincidence, and that holds true for the last 2 quartiles, not just the very last quartile. So we are talking about the last 2 quartiles with low quality care, and that holds true for a lot of Medicaid patients, a lot of patients from Latino and Hispanic origins. So I'll reserve my doubts that it's a coincidence. It's been established beyond doubt that disparities exist, but when you go and ask these populations, do you feel that your care is as good as the majority population, then they strongly think, no, there's a lot of disparity that does exist. A lot of it has to do with where they are in terms of socioeconomic status. At the same time, that reflects how insured they are. There was a story about Damon Driver. I do not know if anyone knows about him, a 12-year-old guy who died because of toothache. And an African-American boy, 12 years old, could not get the insurance, could not get his tooth extracted because he did not have insurance. And while the family tried to get someone to do it for free, they could not do it. And the boy died eventually because of sepsis. And the infection was never controlled. And if you look back, it was just because the health insurance was not there, because the part of the country, he was from Maryland, but like in the areas where it was socioeconomically deprived or poor population. So that's a shame right there for a 12-year-old boy to die because of a toothache. Now, people who are deaf and hard of hearing, they see a lot of partner violence, suicide, obesity, and I can go on and on, believe me, and make it a sad day. But let's move forward. Why did we get here? Like, why is it like some people have an excellent amount of care while the others don't really get as much care? There are a lot of reasons to it. There are primal reasons. Going back to segregation and being marginalized, there is a lot of value in understanding that historical aspect, and that's what we as clinicians, as social scientists, as humanists have the charge to understand what is behind this. And where do we go from there? Ultimately, the point is to eliminate the disparities. And before we do that, let's make sure that we know that it's not a competition with the majorities. It's not a competition with a more privileged society. It's just establishing equity. It's not a rebellion. We don't want to go to the streets and shout slogans. We just want to do the right thing. And you can do by awareness, sensitivity, and thinking of human rights, and educating the public, and coming up with good plans. I put this up. When I was doing so, my kindergarten daughter, she's like, "Dad, this is pretty." And I said, "Yes, diversity is pretty." And yeah, and like I have to go back and explain her what diversity is. That's another story. But like, yes, it's diversity is required both in the healthcare organizations, in the leadership, in the boardrooms, everywhere. You need to make sure that we look much what the society looks like. And this is what I think of how we approach it. And analysis, willingness, and the surveillance and equity reports come through. And we are in great company. A lot of organizations have made sure that they want to do this, and UCSD has shown a lot of intent, but we need to think as the think tanks and make sure that the disparities are taken care of. Let's keep the dialogue open so that we can close it, and the dialogue being the disparities. Thank you, guys.
You have time for some questions? Yeah.
Thank you. Very, very nice talk. I heard on NPR recently that there's a group of doctors also who have these prejudices and biases inside them, and that's partly motivates this different treatment, not just the economic status of the patients. Do you have any comments on that?
Totally. And stereotyping is a very common aspect, and we do see, I actually worked in New York, Bronx, Harlem area also, and there is a lot of thought process, like people want to be in the neighborhoods that are more affluent and cater to people who can pay, and there's a lot of stereotyping, and that has been highlighted as one of the reasons why the disparities exist in the first place in the Institute of Medicine report. It does depend which side of the track was someone born, so it is there, yeah.
So we have time for one more question, and then we're going to have the overall discussion with the panel.
Thank you, guys.
Okay.
Thanks.